Seniors, 11 mistakes that are weakening your memory and hurting your brain. I need you to imagine two numbers taken from the same person, 5 minutes apart, and they tell two very different stories. One number leads a physician to cut a pill dose. The other number keeps the same dose and avoids a dangerous low. One number triggers urgent testing. The other buys time for a careful conversation. If you rely on a home blood pressure monitor, those numbers matter, maybe more than you realize. I'm Dr. Claire Whitmore. I've spent decades in cardiology watching how small, everyday habits turn into big medical mistakes. In clinic, the blood pressure logs patients bring are often noisy. They're full of spikes and dips that aren't disease, they're technique. Today, I'll walk you through 11 common mistakes seniors and caregivers make when measuring blood pressure at home. For each one, you'll hear a short story, a plain explanation of why it skews the number, and a simple fix you can apply immediately. I'll save the single most dangerous mistake for last because it doesn't just add error, it multiplies everything else. Before we begin, a quick reminder. Home readings are one important piece of information for your clinician. They're not a diagnosis on their own, and you should never change or stop medications without talking to your doctor. These tips are about getting reliable numbers so the doctor and you can make the best decisions together. Why technique matters. Blood pressure is the most moment-to-moment sensitive vital sign we use. It responds to posture, motion, emotions, where your arm is, whether your bladder is full, even what you had for breakfast. Small physical changes, standing, crossing your legs, rolling up your sleeve, can push readings up or down by 10, 20, even 50 millimeters of mercury in some cases. When the measurement is inconsistent, the data becomes noise. Your clinician can't tell whether a high reading reflects true cardiovascular risk or just an avoidable mistake. Think of your blood pressure reading like a photograph. A good photo needs the right light, a steady hand, and the right lens. If the camera is shaking or the light is wrong, the picture misleads you. Measurement technique is the photography of blood pressure. If this is useful, please subscribe or share this video with a family member who monitors at home. One short action can prevent a big mistake. Mistake number 11, measuring right after any physical activity. Example, Margaret, 72. She measures right after gardening. Problem, even light exertion raises blood pressure for many minutes. Why? Physical activity increases heart rate and arterial pressure as muscles demand more blood. Blood pressure can stay elevated for several minutes after activity. Typical effect can add 10 to 30 points to systolic pressure. Fix, rest quietly for 5 full minutes before measuring. Margaret loves her rose beds.
Last spring, she went out, pruned for 10 minutes, came inside and checked her monitor. Her systolic was 165. Alarmed, she called her daughter, who urged her to head to the ER. At the hospital, the reading was lower. The ER team could see that Margaret had been active right before the reading. That spike was transient. If she had waited 5 minutes and rechecked at rest, that panic and an unnecessary emergency visit could have been avoided. In physiological terms, activity ramps up sympathetic nervous system activity, your body's go signal, so your arteries tighten and readings climb. 5 minutes of quiet resting lets the heart rate and vascular tone return closer to baseline. Make that the rule. After any exertion, walking to the mailbox, climbing stairs, gardening, sit down for 5 minutes before you put on the cuff. Mistake number 10, measuring with a full bladder. Example, Harold, 78. He checks his pressure without going to the bathroom first. Problem, a full bladder can increase measured blood pressure. Why? The discomfort and reflex responses from bladder distension raise sympathetic tone. Typical effect can raise systolic by about 10 to 15 points. Fix, empty your bladder before measuring. Harold lives alone and keeps a tidy routine, but he often measures first thing without using a bathroom. One morning, his log showed a cluster of higher readings that prompted a medication review. His clinician asked a simple question, did you go right after a night of not getting up? Once Harold started emptying his bladder before measuring, many of those elevated numbers disappeared. It's not about embarrassment. This is physiology. The body reacts to bladder fullness with mild stress responses, and blood pressure is sensitive to that. Wherever possible, use the restroom before you sit for your measurement. Mistake number 9, talking or moving during measurement. Example, Diane, 66. She reads a phone text or talks to a caregiver while the cuff inflates. Problem, speech and movement interfere with the monitor's ability to record accurately and can change readings. Why? Talking changes breathing and upper chest muscle activity. Movement distorts the vascular signals the cuff detects. Typical effect: readings become irregular. They may be artificially high or fluctuate. Fix: stay silent and still during measurement, with both feet flat and hands relaxed. Diane is friendly and social. She often calls her neighbor while checking her numbers. But an oscillometric device depends on steady oscillations in the cuff pressure as the artery opens and closes. Movement and talking add noise. The result is an unreliable number. If the device reports an error or shows a wildly different second reading, the likely cause is motion. Ask the person measuring to be quiet for that minute. The monitor needs stillness to listen correctly. Mistake number 8, incorrect arm position. Example, Thomas, 81. He measures with his arm dangling at his side or propped too high on a cushion.
Problem: if the cuff is not at roughly heart level, readings can be significantly off. Why? Hydrostatic pressure means that for each inch the cuff is below heart level, systolic pressure can read higher. For each inch above, it can read lower. Typical effect: can cause plus or minus 10 to 20 points difference depending on the arm's position. Fix: support the arm so the cuff sits at the level of the heart, sitting with back supported, feet flat, elbow resting on a table. Thomas liked measuring while lounging in his recliner with his arm hanging down. His readings were consistently higher than clinic measurements. When his daughter coached him to sit upright and rest his elbow on a table so the cuff was aligned with his mid-chest, the numbers aligned far better with clinical values. A simple arm pillow or placing a book under the elbow solves this for many. It helps to imagine a horizontal line through the middle of your chest. The cuff should sit on that horizontal plane. If you're unsure, rest your forearm on a table with the monitor on the table beside it. The cuff will usually be near heart level that way. Mistake number 7, wrong cuff size. Example, Ruth, 69. She uses a one-size-fits-most cuff that slips on her narrower arm. Problem: if the cuff is too large or too small, measurements are inaccurate. Why? A small cuff squeezes more tightly and can overestimate pressure. An oversized cuff may underestimate it. Typical effect: errors can be large, up to 50 points in some mismatched cases. Fix: measure mid-arm circumference and use a cuff recommended for that range. Ruth bought a cuff at the pharmacy labeled Fits Most. Her arm is on the smaller side, and the cuff rolled, so it didn't compress the artery uniformly. Her readings tended to be higher, and that led to anxiety and calls to her primary care office. When the clinic measured her mid-arm circumference, they recommended a smaller cuff size, and her home readings corrected substantially. If you're unsure what cuff size you need, your clinic can measure you, or many home devices list recommended arm ranges on the box. A cuff that fits snugly, with the bladder centered over the artery and the lower edge about an inch above the elbow crease, will give the most reliable result. Mistake number 6, inconsistent measurement times. Example, Franklin, 74. He measures at different times, sometimes right after breakfast, sometimes before bed. Problem: blood pressure follows a circadian rhythm. Measurements taken at different times can't be compared directly. Why? BP is typically lower during sleep and rises on waking. Activity and medications create predictable daily patterns. Typical effect: readings vary across the day. Inconsistent timing makes trends meaningless. Fix: measure at the same 2 times every day, usually before the morning dose of pills, after the 5-minute rest, and before dinner. Franklin's log looked like a roller coaster, low in the morning one day, high the next.
His clinician asked whether he had a strict measurement schedule. Once Franklin started taking readings at the same times each day, pre-morning medication and pre-evening meal, the logs revealed a clear pattern that his doctor could use. Consistency is the key to identifying trends. If you measure randomly, the data will reflect the time of day rather than long-term blood pressure control. Choose fixed times aligned with your routines and stick to them so the numbers can be interpreted correctly. Mistake number 5, not keeping an accurate log. Example, Sandra, 70. She writes rough memory notes or relies on recall. Problem: memory is unreliable. Scattered or incomplete notes make clinical interpretation impossible. Why? A clinician needs date, time, and exact readings to detect patterns and make safe decisions. Typical effect: clinicians can't distinguish systematic high readings from isolated spikes. This may lead to overly aggressive or conservative care. Fix: record the exact date, time, and each reading. Note if you were stressed, had just exercised, or were taking medications. Sandra thought she could remember around 140s from the week. In clinic, that vague recollection wasn't helpful. A device with built-in memory helps, but pairing that memory with a written or digital log where you note the time and any relevant circumstances makes the data useful in the clinic. If the reader wants, a printable log sheet that the clinic can review is a practical tool. Why logs matter so much? Imagine a doctor seeing 4 morning readings all at 160 versus 4 at 140. Management changes. If your log mixes morning and evening values without timestamps, the doctor may misinterpret variability as lack of control. Good logs are the bridge between home measurement and safe medical decisions. Midway pause. How these errors stack up. If you're counting, we've covered 6 mistakes so far. Each one alone can nudge your reading by 10 to 30 points or more, but they rarely occur in isolation. Picture Margaret stepping inside after pruning, no 5-minute rest, squeezing into her clothing with the cuff over fabric, chatting as the cuff inflates, and measuring at an odd time of day. Those small errors don't add, they compound. A cuff placed over clothing that's too tight, measured right after activity with the arm hanging, can produce a reading far from the person's baseline. That's precisely why mistake number 1, the cuff over clothing, is the most dangerous. It not only distorts a single reading, but makes other errors worse, and I'll explain exactly why when we get there. I want to emphasize this clearly. These are common, correctable mistakes. I'm not blaming anyone. Most patients come to clinic with good intentions. They're trying to be proactive, but the data they bring can mislead clinicians when the measurement conditions are inconsistent.
The rest of this video will continue through mistakes 5 to 1, and then give you a gold standard step-by-step protocol you can follow every single time to create reproducible, clinically useful readings. Before we continue into the remaining mistakes, let me briefly note something for clinicians watching. These recommendations are about measurement technique, not treatment adjustments. Use home readings as data points to guide an informed clinical conversation. If your patient's readings change significantly after a technique correction, consider reassessing medication before escalating doses. Coming up next, we'll walk through mistakes 4 through 1, including how to check both arms and why taking only a single reading is misleading. We'll also go step by step through a gold standard protocol you can use immediately. But first, let me tell you one more story that ties together what we've already discussed. A short composite, the patient who looked hypertensive but wasn't. I want you to meet Patricia. This is a composite drawn from many similar clinic encounters. Patricia is 67 and has been living with a diagnosis of borderline high blood pressure for years. She brought a log showing several 70s of readings in the 150 to 170 range. The clinic consulted the log and, without a reliable pattern, was ready to increase medication. But a nurse took her aside and observed the home measurement routine. Patricia had been measuring after climbing a flight of stairs from the garage, while wearing a sweater with the cuff over the fabric and talking on the phone. The clinic performed a careful standardized measurement: proper cuff size, arm at heart level, empty bladder, 5 minutes rest, and obtained a pressure 20 to 30 points lower than her morning home entries. That lower, reproducible value changed the plan. Instead of adding another pill, the team spent time correcting measurement technique at home and arranging for a repeat 2-week log at the agreed times. The lesson here is clear. Data corrupted by technique leads to questionable clinical choices. That can mean unnecessary medication adjustments with side effects, increased costs, and added worry. When we fix the technique, many patients' apparent problems resolve, or at least become clearer and safer to manage. A practical pause: what to do right now. If you're watching this with a family member, caregiver, or for yourself, take 3 quick actions before we continue. 1. Make sure the person measuring is sitting and quiet for 5 minutes before the cuff goes on. 2. Check that the arm is supported at heart level. And 3. Put a note on the monitor to measure at same times each day. These small steps will already improve the quality of the readings. We'll return in a moment to the remaining mistakes and the full protocol. The next segment will cover measuring while stressed, checking both arms, taking only a single reading, and the cuff on clothing error that multiplies other mistakes. Each of those can flip clinical decisions. I'll explain how to spot them and correct them, and then I'll give you the exact sequence to follow every time you measure, so your logs become reliable medical tools. Hold on to the idea that consistency is the goal. Same arm, same position, same time, same technique. Do that, and your home monitor becomes a powerful ally rather than a source of confusion.
Now let's move into mistake number 4 and the next ones. Pay attention, because the next errors are the ones that most often push clinicians to intensify treatment unnecessarily. Mistake number 4, measuring while stressed or upset. Example, Edward, 75. He checks his pressure after an argument on the phone. Problem, strong emotions and acute stress spike blood pressure for minutes to hours. Why? Stress activates the sympathetic nervous system, heart rate climbs, vessels constrict, and blood pressure rises transiently. Typical effect, readings can be temporarily higher than baseline. The exact rise varies by person. Fix, step away from upsetting conversations, sit quietly for 5 minutes, take a few slow breaths, then measure when calm. Edward is a proud, private man who hates to bother his family. One evening, he received a call that left him shaken. He sat down and took his reading immediately afterward, 170/88. Alarmed, his granddaughter urged him to call his doctor. The spike corresponded with his emotional state, not a change in long-term control. When Edward waited until he had calmed, his pressure returned close to his usual numbers. The practical lesson here is simple and humane. Emotions matter. If you feel upset, take a moment. A calm measurement is an honest measurement. Mistake number 3, not checking both arms initially. Example, Patricia, 67. She always measured only her right arm. Problem, a meaningful difference between arms can signal vascular disease and will alter which arm should be used for ongoing monitoring. Why? Anatomical or vascular differences can cause persistent interarm systolic differences. A consistent gap suggests the higher arm better reflects true central pressure. Typical effect, an interarm difference greater than 10 millimeters mercury is clinically notable and should guide which arm to use. Fix, during the first week of home monitoring, alternate arms and record readings from both. Then use the arm with the higher values if a consistent gap greater than 10 millimeters mercury is present. Patricia's clinic visit highlighted this. Her home readings were erratic, but when staff measured both arms, they found a reliable 12 millimeters difference favoring the left arm. After switching to the left arm for all home measurements, her logs became consistent and useful. Checking both arms once, early in the monitoring plan, prevents a hidden bias that would otherwise skew every subsequent reading. Mistake number 2, taking only one reading. Example, Vincent, 73. He checks once, records a single number, and stops.
Problem. The first reading is often influenced by the act of sitting down, anxiety about the device, or residual activity. Single measurements miss that natural settling effect. Why? Blood pressure often falls slightly after the initial cuff inflation as the body relaxes. Averaging multiple readings smooths out transient spikes and random variation. Typical effect. The first reading can be higher than the subsequent 2. Relying on it alone risks overestimating true pressure. Fix. Take 3 readings, 1 to 2 minutes apart, after a 5-minute rest. Average the second and third readings and record that average. Vincent was meticulous about checking every morning, but frustrated his doctor by bringing just one number. When he agreed to measure 3 times and averaged the last 2, the apparent instability in his logs disappeared. This simple routine converts a noisy single snapshot into a reliable trend. For most people, the average of the second and third readings is the value a clinician will trust most. Mistake number 1, cuff over clothing or a rolled-up sleeve, the multiplier. Example, Alice, 71. She measures through her sweater sleeve because it's cold. Problem, fabric under the cuff changes how the cuff compresses the artery, often mimicking a tourniquet effect or preventing uniform bladder expansion. Why? A cuff over clothing can cause false elevation by creating an uneven interface between cuff and skin. The cuff may compress fabric rather than the artery, and a rolled sleeve can fold and constrict. Typical effect. This error can create large artificial increases in measured pressure and intensify other mistakes. Even activity or wrong arm position becomes worse when the cuff is over fabric. Fix. Always place the cuff directly on bare skin, no clothing between the cuff and upper arm. If cold is an issue, take the measurement with the cuff on skin and cover yourself with a blanket afterward. Alice lived in a chilly house and didn't want to go without her sweater. When she started measuring through the fabric, her readings jumped frequently into ranges that frightened her and her family. Clinic observation found the cuff over clothing and a partially rolled sleeve.
Once she measured on bare skin, the home numbers consistently dropped by multiple points and matched clinic measurements much better. This is the single most dangerous and misleading error because it not only distorts a reading itself, but amplifies the impact of other technique mistakes. Treating cuff over clothing as a hard rule, never do it, will remove the largest source of avoidable error in many home logs. Compounding errors, how small habits multiply into big consequences. We've walked through 11 distinct errors. Each one matters on its own. Put several together, and the result is not a simple sum, but a multiplication of uncertainty.
Imagine a morning routine that includes climbing steps to the kitchen, no 5-minute rest, measuring while emotionally upset by a phone call, slipping the cuff over a long-sleeved sweater, and taking only one hurried reading. Any single error might add 10 to 20 points. Combined, they can produce a reading so far from baseline that it prompts unnecessary doses, repeat clinic visits, anxiety, and even dangerous low blood pressure if a clinician responds by adding medications. Conversely, correcting technique often reduces apparent readings substantially, sometimes by 20 points or more, and prevents needless treatment changes. This is why the cuff on skin rule is so critical. It changes the mechanical interface of measurement and makes other errors more meaningful. A cuff over clothing behaves inconsistently across different body positions and activities, so when you eliminate clothing as a variable, the remaining errors become easier to spot and fix. Reproducibility is the goal. If your numbers are reproducible, same arm, same time, same position, same cuff conditions, the clinician can make safe, informed choices. A clinician note: Hallie use corrected home data. For clinicians watching, a brief word on interpretation. Treat home logs as longitudinal data. After a technique correction, allow a short reassessment window, often 2 weeks of consistent readings, before making major medication changes. If a patient's post-correction logs are significantly lower and reproducible, consider reevaluating the need for dose escalation. Remember that home readings are supplementary. Integrate them with office measurements, symptoms, and clinical context. Gold standard, step-by-step home blood pressure protocol you can use every time. Now I'll give you an exact sequence to follow every time you measure at home. Think of this as the recipe for reproducible readings. Do these steps in order, and the numbers you log will more likely reflect true blood pressure rather than noise. First, choose consistent times each day for measurement. Most clinicians prefer a morning reading before you take your morning medication and a second reading before dinner. Tie the measurements to routine landmarks so you don't drift. Second, avoid caffeine, smoking, or exercise for at least 30 minutes before measuring. These actions temporarily affect heart rate and blood pressure. Third, empty your bladder. A full bladder produces a mild stress response that raises readings. Fourth, sit quietly for 5 full minutes before putting the cuff on. This is non-negotiable. 5 minutes of quiet rest brings your baseline closer to its steady state. Fifth, sit in a chair with your back supported and both feet flat on the floor. Avoid crossing your legs. Rest your forearm on a table so the cuff will be at roughly the level of the middle of your chest. Sixth, place the cuff on bare skin, no clothing between cuff and arm. The lower edge of the cuff should be about an inch above the elbow crease and the bladder centered over the artery. If you're not sure about cuff size, have a clinic measure your mid-arm circumference and note the correct cuff range. Seventh, take 3 readings, spaced 1 to 2 minutes apart. Do not talk or move during measurement. If your monitor shows an error, wait a minute and repeat. Eighth, average the second and third readings and record that average as the value for that session. Also record the exact time, which arm you used, and any relevant notes, if you were stressed, had just walked, or felt unwell. Ninth, keep a written or digital log and bring it to your clinician. If your monitor stores readings, pairing those stored values with a time-stamped paper or app log is ideal. If you're monitoring both arms initially, note the arm used and then standardize to the chosen arm for all future readings. These steps produce a reproducible measurement. I want to stress that reproducibility, not perfection, is what clinicians need to make safer decisions. Following this checklist each time reduces random spikes and helps your clinician decide if treatment adjustments are truly necessary. Practical tips that make the protocol easier to follow. Small practical changes make adherence realistic. Keep your monitor in a convenient place at chair and table height so you don't have to hunt for it. Put a sticky note on the monitor that says, "Rest 5 minutes, bare arm, take 3 readings." If your hands are shaky or arthritis makes cuff placement difficult, ask a caregiver to help or discuss an alternative cuff design with your clinic. If you feel embarrassed measuring in thin clothes, remember that a light t-shirt under the cuff is still fabric. Remove it briefly while measuring and replace it afterward.
Consistency beats perfection. It's better to follow the routine reliably than to aim for flawlessness every single time. How corrected technique changes outcomes, a composite case. Let me tell you George's story, a composite drawn from several patients, that shows the difference technique makes. George is 79, retired after a long career, and lives with his daughter. For months, his home log showed morning readings clustered around 160. His primary care physician considered adding a second antihypertensive medication. George worried about dizziness and falls. The clinic nurse observed George's home routine and found several compounding issues. He measured right after climbing the stairs to the kitchen, sometimes while still wearing a heavy sweater, cuff over fabric, and he took a single reading without waiting. The nurse coached George through the gold standard sequence: empty bladder, 5-minute seated rest, cuff on bare skin, arm at heart level, and 3 readings averaged. 2 weeks later, George's morning average was consistently closer to 135.
With reproducible data, the clinician deferred adding a second drug, adjusted timing of his existing medication, and scheduled a follow-up with a focus on lifestyle and fall prevention. George felt relief, fewer pills, fewer side effect worries, and better confidence in his numbers. His daughter learned the protocol too, so measurements at home became a shared, gentle routine rather than a source of stress. Notice 2 things in George's story. First, the original data looked alarming but was largely artifactual. Second, correcting technique created clarity that allowed a safer, more measured clinical approach. This is the clinical power of good measurement. When numbers remain high despite perfect technique. It's important to say what happens when you do everything right and the numbers are still high. If you follow the protocol consistently and your average readings remain elevated, those numbers are meaningful. They reflect an elevated physiological baseline that your clinician should address. The key is that treatment decisions made on reliable data are safer and more rational than decisions made on noisy logs. If your readings are persistently high, schedule a discussion with your clinician. Bring your log, describe any symptoms like lightheadedness or chest pain, and ask about next steps. Never stop or change medication without professional guidance. These logs are tools for an informed conversation, not a substitute for clinical judgment. Common questions I hear in clinic. Patients and caregivers often ask whether different monitors matter and how to choose one. Most validated upper arm oscillometric devices from reputable manufacturers are adequate. Wrist monitors are more sensitive to position and generally not recommended for routine home surveillance in older adults. Whatever device you use, pick one that fits your arm size, is validated, and has a clear display. If in doubt, bring the device to clinic and compare it with a standardized measurement. That comparison lets you know whether the device is behaving as expected. Another frequent question: how often should I send logs to my clinician? If you're monitoring for routine control, a 2-week log of morning and evening readings at the same times is usually enough to show a trend. If a clinician asked for more intensive monitoring, follow their instructions. But indiscriminate daily uploads without technique consistency create noise, so prioritize quality over quantity. How caregivers can help without taking over. Caregivers play a vital role. They can help with cuff placement, ensuring 5 minutes of rest, recording times, and calming an anxious patient before measurement. The goal is to empower the person being monitored while providing consistent technique. Avoid hovering or creating pressure around the measurement. Stress itself can skew the numbers. Gentle assistance and non-judgmental reminders work best. What to do if readings diverge from clinic values? Occasionally, patients bring home logs that diverge from clinic readings even after technique correction. In those cases, consider 3 possibilities. First, there may be an arm selection issue. Recheck both arms. Second, cuff size may still be wrong. Reconfirm mid-arm circumference. Third, the monitor may be malfunctioning. Bring it to the clinic for side-by-side testing. If technical issues are excluded and home readings remain higher, that's important clinical information and should prompt further evaluation. A short checklist to memorize. It helps to rehearse a short phrase before measuring. Rest 5, skin bare, arm level 3 times. That little mantra captures the essentials and is easy to remember. Stick a note on the monitor with those words. Small memory aids reduce slips and make the habit sustainable. Safety reminders and seeking urgent care. If you or the person you care for experience severe symptoms, sudden chest pain, shortness of breath, fainting, or neurological signs like sudden weakness or speech changes, seek immediate medical care. Home blood pressure measurements are an important monitoring tool, but do not replace urgent clinical assessment when severe symptoms occur. For routine high readings without symptoms, use the data to arrange timely follow-up with the clinician rather than panic-driven ER visits. Final practical wrap-up. Measure at the same times each day.
Rest quietly for 5 minutes. Use a properly sized cuff on bare skin. Support the arm at heart level. Take 3 readings and average the second and third. Log the time and conditions and share the log with your clinician. These steps are not complicated, but they demand routine. The payoff is clarity, fewer false alarms, fewer unnecessary medication changes, and safer, more confident clinical decisions. Closing story and outcome. I want to close with one more brief vignette about Franklin's neighbor, George's sister-in-law, this time focusing on the emotional payoff of doing it well. After learning the gold standard protocol, she became the household expert on morning measurements. She set a gentle routine, kept a simple log, and brought it to the clinic. The clinician compared the corrected home values with office readings and adjusted the plan conservatively. More than that, she felt empowered. She stopped dreading the morning numbers and began to see measurement as a useful check-in rather than a judgment. Her anxiety about blood pressure decreased, and the family regained calm over what had been a constant source of worry. A call to action and clinician reminder. If this video helped you, please share it with a family member or caregiver who monitors blood pressure at home. Teaching these steps to one person can protect many. Keep a copy of your log and bring it to your next appointment. Remember, do not change or stop any medications without talking to your clinician.
If you like, check the video description for a printable checklist and a simple log sheet you can download and use at home. Parting reassurance. Most monitoring errors are fixable. You are not to blame if your numbers have been noisy. With consistent technique, same times, same arm, bare skin, 5 minutes rest, 3 readings, you can transform home blood pressure from a source of worry into a reliable tool that helps your clinician take the safest path for your health. Thank you for letting me guide you through these practical steps. Share this with a loved one who measures at home. Bring your corrected log to your clinician, and if you found this useful, consider subscribing so we can cover more simple, high-impact tips for staying healthy as you age.